Welcome to the Lean Blog Podcast. Visit our website at www.leanblog.org. Now, here's your host, Mark Graban.
Hi, this is Mark Graban. Welcome to episode 146 of the podcast for May 2nd, 2012. Joining me today is Dr. John Toussaint. This is his fourth appearance on the podcast. He is the CEO of the ThedaCare Center for Healthcare Value. And today we're talking about his latest book called Potent Medicine, the Collaborative Cure for Healthcare. In the book and in the podcast, John talks about the three aspects of this collaborative cure. First being patient-centered care redesign, second being transparency, and third being payment for outcomes. So a lot of the discussion follows up on my conversation with Dr. Dean Gruner, the current CEO of ThedaCare, the health system, back in podcast 144, where Dean was talking about their experiments with accountable care organizations there at ThedaCare. For past episodes, you can go to leanpodcast.org, and as always, thanks for taking time out to listen. Well, John, it's great to have you back on the podcast talking about your new book, Potent Medicine. Thanks for joining us.
Thank you, Mark. We're excited about this new book and be happy to talk to you about it.
Yeah, so I have the advantage of the book in front of me. A lot of the listeners might not have the book because it's been just very recently released, Potent Medicine, the Collaborative Care for Healthcare. So, John, can you kind of introduce the book for the listeners, kind of give us a the high-level summary, how the book came to be, and we'll dive into some of the main points.
Well, we've been on the lean journey at ThedaCare for almost a decade now, and we've learned that there are several other things that are pretty important to true health reform. In addition to redesigning care using the lean methodology, we also need to have a payment system that actually rewards organizations that are delivering better care. In other words, pay for value rather than pay for volume. The other thing that we've learned is that if the customer, the patient, doesn't actually know who's delivering better value, so doesn't have the information and the data, then the whole system doesn't work. So what we've really designed with Potent Medicine is one-piece flow for healthcare reform, which includes payment redesign that rewards value, transparency of healthcare performance so patients know who's delivering the best value, and care redesign using lean.
And a lot of what you're writing about is born from your experience when you were still CEO of ThedaCare and for what's been happening since when another recent guest of mine, Dr. Dean Gruner, the current CEO, has been in charge of leading ThedaCare. Can you talk a little bit about some of those experiences that led you to realize that these other pieces beyond just that great lean improvement work were necessary?
Well, first of all, this book is not a book of theory. It's actually a book of experience, and it's the experience that we've had not only in using lean to redesign care processes at ThedaCare, but also all of the work that we've done throughout the state of Wisconsin and bringing organizations together, insurance companies and state government officials and employer groups and provider organizations to talk about what the real issues are in health reform. And so this is actually work that we've done over the last few years where we actually created the Wisconsin Collaborative for Healthcare Quality and publicly reported physician performance measures, and we created the Wisconsin Health Information Organization and are about to publicly report cost information on physicians as they through episodes of care of their patients. So what we've done is we've taken that experience and we've written this book about how powerful these types of activities are in actually changing behavior, not only of physicians but also of people who pay the bill and even patients.
Right, and these Wisconsin collaboratives and organizations that you mentioned, for the listeners, I'll have links to these organizations if you go to leanpodcast.org and find the specific page for this episode of the podcast. Because there is, as you mentioned, John, a lot of data that's available, far more data than here in my home state of Texas. I was wondering if you could share, let's transition to talking about some of the connections between patient-focused redesign of care and, let's say, transparency. Are there specific instances from your experience where an organization like ThedaCare or others that you're familiar with have made improvements to that value equation of quality and cost? I mean, if they're making that improvement and patients can't find them, what are some of the things that you've seen either kind of trip up organizations or some of the successes that you've seen from making that data available in Wisconsin?
Well, what was interesting is that in Wisconsin you can compare the Marshfield Clinic to ThedaCare to the Mayo Clinic to Gunderson Lutheran. These are all great organizations. But the reality is that we can all be better. We can all improve. And so at ThedaCare, for example, using the lean process to redesign the outpatient patient experience has led to dramatically improved quality of care in diabetes and heart disease. And you can actually go on the website, the Wisconsin Collaborative website, and see how ThedaCare performs on, how many of their heart disease patients, for example, have their bad cholesterol under 100, which is where it should be. How many of their diabetes patients have their blood sugar controlled with an overall blood sugar test called an A1C under 7. And what ThedaCare has done is, using the lean principles, collapsed the time required for patients to get care and then done more of the care in the single visit. So, for example, a patient comes in, has their blood test drawn the minute they show up to the clinic. The blood test is actually run while the patient is in the room with the doctor, and the doctor gets the results within 15 minutes and can actually then have a conversation with the patient about, changing the medications for the diabetes control or the high blood pressure control. So it avoids all the callbacks and all these things where we sort of drop the ball. And what that's led to is dramatically better quality. And now the patients can actually go on the website and find who's actually delivering the best quality in diabetes care, the best quality in heart disease care in the whole state.
And so some of that's available, the quality data is available. Some of the other factors patients might look for in terms of where can they get in for an appointment most quickly. I mean, some of that fall, some of the output of that lean redesign, does that fall on the hospitals and health systems to sort of try to communicate and use that in their marketing, or is it just something that becomes known within communities that you can get in here more quickly and get that high quality, great value care?
Well, what you can do on the website, the Wisconsin Collaborative website, is actually you can actually find out how long does it take for you to get an appointment with a doctor in any clinic in the state. So you can determine whether you can be seen today or not, for example, in all the clinics in the state. So we have measures of access, we have measures of quality, we have measures of quality and cost. You can actually get a pretty good picture of where you probably ought to be going in the state of Wisconsin, depending on what condition you have.
Okay, great. So that access piece, I guess in a way that's a different aspect of healthcare quality. Being able to be seen and get diagnosed or treated more promptly is going to lead to better outcomes, right?
Correct.
Yeah. One thing I wanted to ask you about, you wrote about in the book about transparency, that I thought was interesting. It was talking about the difference between outcomes measures and process measures. I was wondering if you could share some of your experiences and what you see being measured today versus what your recommendations are in the book Potent Medicine.
Well, there was an interesting article recently that showed that the process measures that the premier demonstration project with CMS, that those process measures did not lead to any change in mortality rates in hospitals. And so what we're finding and what we've known is that if you use process measures, so this would be like, for example, you come to the emergency room, you're having a heart attack, did you get an aspirin? That's a process measure that, did we actually do something? But we don't talk about, did you lose half of your heart muscle? That's an outcome. Or did you die? or did you, so those are outcomes measures. And so what we really are interested in is what are the outcomes of care, not necessarily what the process measures of care are. What are the outcomes measures of care? And when you report outcomes measures, then what happens is organizations, we go back and really look at the root causes. Care processes are so much more complicated than just, a series of process measures. And so what you really need are the outcomes measures so that can then help guide you back to what the root causes of the poor outcomes are, which then you can redesign the process using the lean principles to actually improve the outcomes. So we're a big believer in reporting outcomes measures, and we're not too high on whether you actually gave the person the test or whatever, because you could have given the person the right test 100% of the time and still had a poor outcome.
Right. Is some of this maybe a matter where those process measures are not really good predictors of the outcome? Is that where some of that disconnect maybe comes from?
Yeah, I think the issue is that there are too many process measures that are required to actually predict the outcome. In fact, most of the time we don't have all of the process. We actually can't have all of the process measures because there are hundreds of them. And so what we really need is what actually happens. So what's the outcome? And then what has to happen is the organization has to go back and redesign the care process after they do the root cause analysis. So we're from a transparency world perspective, we're suggesting that these process measures are important, and the reality is what we're finding is they really aren't very important. And it's more important for the organization to deeply understand what it is that they're doing so they can understand how to redesign their care.
Okay, thanks. And the other interconnection I think would be good to delve into is looking at patient-focused lean care improvements with the issue of comprehensive payments. When we talk about the problems, like you'd elaborated on this too, the problems that come from the fee-for-service payment model. Back in the manufacturing world, we would call this a piecework model, where people are being paid for activity. Something that I think a lot of manufacturing moved away from. What are some of the things that either, let's say tripped up organizations like ThedaCare, where they made improvements and that fee-for-service model didn't really reward them for that improvement, or some examples of cases where alternative payment methods have helped? Can you explain some of that for us?
Yeah, so one of the problems in a fee-for-service world, because we are exactly in a piecework world. So part of that problem is, I wrote in my first book On the Mend about how we actually delivered babies at a later time in gestation. If you deliver a baby before 39 weeks, those babies end up in the intensive care unit. Well, we now know that based on evidence-based medicine that you should never deliver a baby before 39 weeks. So we moved to delivering 100% of our babies after 39 weeks, and that reduced the number of babies that were going into our ICU. And in the fee-for-service world, we actually got paid for babies going into the ICU. So we reduced the number of babies in the ICU by 50%, and we therefore reduced our revenue by 50%. So that's one of the core, elements of dysfunction in this payment system. So we need to move to a payment system that actually helps reward us to keep people healthy and to have better health outcomes. And what that means is we need to move to a more of a global payment system or comprehensive payment system where we actually get prepaid to take care of people in a way that maximizes their health rather than waits for them to get sick and then we get paid. Now, in the new book, I actually give a very specific example of a diabetic patient who from a hospital perspective, we get paid a lot more money to actually do an amputation on that diabetic patient than we do to keep the diabetic patient healthy and at home. And for a year's worth of preventative care, we get paid about $2,500. But if the patient, was not well taken care of, did not have preventative care, and needed an amputation of a toe or part of the foot, we get paid $33,000 for that. So the question is, shouldn't we get paid to actually keep the diabetic patient as healthy as possible, not do those amputations, not have those complications? Well, of course, the obvious answer is yes, but yet the reward system today is not set up to reward us for doing that.
Yeah, and I recently talked with Dean Gruner about ACOs, or accountable care organizations. Is that one of the primary ways that you think this comprehensive payment model is going to be implemented, or are there alternatives? What are your thoughts on that?
Well, ACO is one experiment that will be tried. We don't know exactly what's going to work. So, ThedaCare is participating in the Pioneer ACO program. There are 32 organizations in the country that have agreed to do this. This is a big experiment from Medicare. And the payment system is based on year-over-year improvement in total cost of care and quality of care, and then when you do reduce the cost, you get a piece of the savings. But it is an experiment in which the basic concept is, can we look at the payment system from a global perspective? So you take a large number of patients, in this case it's about 24,000 patients, and can you actually deliver more cost-effective care year over year? And I think organizations that are using lean to take waste out of the system should be able to do that. So this payment mechanism may actually reward delivering better value, but obviously we have to study it, we have to try it. I'm very glad that ThedaCare's agreed to be part of the solution rather than the problem. So they're actually going to be one of the experimenters. It's scary to take 24,000 of your patients and all of a sudden get paid completely differently when you really don't know what to expect. But this is the sorts of courageous behavior that's going to be required in our industry.
And as Dean explained it, he said, it was an experimental step of taking a subset of ThedaCare's patients rather than, betting everything on, a big change all at once. So that seems to fit with whether you call it the scientific method or the PDSA cycle that people working with lean are so familiar with, that they're taking steps, and as you said, let's work and see what's effective or not.
Yeah, and in the book, I don't make any bones about the fact that we don't know the answers yet. But what I do is say we need to run the experiments, and I give some examples of what experiments should be run and are being run. And then our commitment to the industry is that on our website at createhealthcarevalue.org, that we will publish the work that's going on in these experiments in payment redesign, so that we can all learn from them as quickly as those learnings are being accumulated.
Sure, and the cover of the book is reminiscent. I mean, the cover image, if people go and look at the book, even while they're listening to the podcast here, the dropper and the test tube, that's meant to invoke this experimental mindset, right?
Correct. As we have a lot of work to do here. This work is not done in any way, shape, or form. We have to connect the payment system to the delivery redesign using lean, and then we have to make sure that our customers, our patients, know what the results are. And those are all quite experimental concepts, especially tying them all together into one-piece flow, which is really what we've tried to do with the thinking in this book and the thinking in some of the experiments that we're running in Wisconsin.
Mm-hmm. So as kind of wrap things up a little bit, I'm curious to hear your thoughts on two aspects of the broader healthcare reform discussion. First off, what sort of alignment is there, if any, of these three ideas of transparency, comprehensive payments, the patient-focused care redesign, those three elements with what had been passed in the Patient Protection and Affordable Care Act? And then the second part of that, what can listeners do Should they be trying to contact congressional leaders at the federal level, with state leaders, or both? What are your thoughts about how this fits in there?
Well, the first question is certainly in the Affordable Care Act, there are parts of the Affordable Care Act that start to address some of these problems. So, for example, the Medicare data, which we very much need in our data sets here in Wisconsin, the legislation does allow the release of Medicare data to organizations like the Wisconsin Health Information Organization. But the problem is that the requirements for that release make it almost impossible for the Wisconsin Health Information Organization to use the data in a way to give reports to physicians to allow them to improve. So that particular component of the Affordable Care Act needs significant improvement if it's going to be practically implemented. Other parts of the Affordable Care Act, such as the Medicare Innovation Center, the experiments that they're running with payment reform, I think are right on. So the Pioneer ACO program is one of those experiments. There's another experiment with comprehensive primary care payment. So these are good things. These are good experiments that the federal government and Medicare should run. And so there are some things, right, that actually make sense in the Affordable Care Act that can help us with these. But the reality is that the federal government needs us locally in states to actually do some of this work and to experiment with it. So again, the idea here is this is a collaboration. We have to collaborate with the government and the private sector. We have to collaborate with the employers, the insurance companies, the provider systems, the state governments, and the federal government to actually, work on these experiments to see what works and then to move to policy that supports that. And all of that is, somewhat beyond what the Affordable Care Act is describing. So we've got a lot of work to do yet from a governmental perspective, in my opinion, and I'll be spending significant time with, and have been, with government officials to try to explain these things. As far as, what can you do next Tuesday, I guess I'd look at it from your audience's perspective. First of all, if you're an employer, or you work for an employer, I think that there's some things that we need to stop doing on Monday, which is we need to stop buying on discounts. So right now, most employers buy their insurance products, and the insurance company comes to them and says, well, I got a bigger discount with ThedaCare than, my competitor, so you should, buy your insurance from me. The reality is that type of an insurance process is what's gotten us into this disaster that we're in from a cost out of control perspective. So employers need to stop buying on discounts. If they're self-funded, they need to release their data to organizations like the Wisconsin Health Information Organization. They also need to get focused on their own employee health performance, do health risk assessments, consider getting on-site clinics going in their companies, and then design benefit plans that actually get the patients involved in trying to help figure out where the best value is in healthcare. So there are quality and cost websites now that patients need to be going to. If you're a patient, I think there's some, and we're all patients. So what do we need to do as patients? We need to ask our doctor, why should I have this test? Based on what evidence? Why should I have this treatment? You're going to prescribe antibiotics to me. Well, why, when 98% of the time antibiotics are completely ineffective for this problem? Well, guess what? We need to educate ourselves, right? We need to ask doctors, if you're going to have surgery, how many surgeries did you do last year? And what was your infection rate? What are your outcomes? Doctors ought to be able to tell us that as patients. And the same questions for the hospitals. What's your infection rate? What's your mortality rate for heart surgery? These are all things that we just sort of take for granted, that the doctor is in charge and is going to do all the right things. Well, the reality is that we have to become informed consumers as patients, and we're not today.
Well, so it sounds like there are a lot of very practical actions we can take, both locally, in the exam room, or trying to research care that we need, or trying to help communicate with our political governmental leaders. So, John, I want to thank you for sharing that great overview of the new book, Potent Medicine. The subtitle is The Collaborative Cure for Healthcare. So I certainly want to wish you luck with the book. And you're going to be, one other thing maybe if you mention real quick, you're going to be keynoting and talking about the ideas here at the upcoming Lean Healthcare Transformation Summit. If you can tell the listeners a little bit more about that great event.
Yes, we're in Minneapolis, June 6th and 7th. We will be bringing together the best lean healthcare organizations around North America. They will be doing lots of presentations. Mark, you're going to be part of that presentation group as well. And we're going to actually delve more deeply into some of these issues of how do we pay for value that's being created in lean organizations, and how do we make that more transparent, both from a national perspective and make it personal. So we're going to have a lot of interesting arguments and conversations and dialogue about what really needs to happen in health reform on June 6th and 7th in Minneapolis. So I invite you all to be there and meet us and talk with us about it more.
And people can find more at createvalue.org. They can also find information at the LEI website, lean.org. Is that right?
Correct. So we do this conference in partnership with LEI, which we do many things with in partnership with Lean Enterprise Institute, and John Shook will be one of our keynote speakers at this year's conference, who is the CEO of the Lean Enterprise Institute.
Yeah, well, I'm really looking forward to it, and there's going to be a lot of great networking and discussion with the attendees. It's always a great crowd that comes in to attend. So, John, thanks so much for talking about the new book, and good luck, and I hope it gets into a lot of readers' hands real soon.
Thank you very much, Mark.
Thanks for listening. This has been the Lean Blog Podcast. For Lean news and commentary updated daily, visit www.leanblog.org. If you have any questions or comments about this podcast, email Mark at leanpodcast@gmail.com.